All right, welcome everyone. Welcome to all those in the audience here at LSI 25 Asia, as well as those who are joining us online around the world. This is the panel on the aging brain. Today, my name is Daniel Teo. I'm managing partner and co-founder for Hunniwell Lake Ventures. We are a medical device fund that invests in the cardiology, neurology, and surgical oncology space. Now, you would ask why those three areas? Well, when we were considering, the scope for our third fund, which is our current fund now, we polled our LPs and potential investors and asked them what were the three most worrisome health concerns that they have. And consistently, the answers came back: cancer, the heart, and neurological health. I mean, those were the three things that worry people the most. Everything else was sort of survivable, right? And so, therefore, that became the foundation, the three pillars for our current fund. Now, aging health is certainly a problem. I've got some statistics here. The WHO, says that there are about 55 million people around the world suffering from dementia. In the US, 1 in 9 persons, or 11% of the elderly above 65 years old, also suffer from Alzheimer's. That's 6.7 million patients. So certainly, neurodegeneration and neurotrauma is placing an enormous strain on just caregivers and also the health systems. And don't forget TBI when we're talking about neurotrauma. In the US, there are about 1 million cases of TBI a year. And we all know that those who suffer TBI also are 2 to 5 times the higher risk of suffering from dementia. So these are all concerns and problems that I think we have a solution for, and we're trying to address. So today we are glad to have a diverse and stellar panel with us, comprising physicians, investors, and entrepreneurs, and even patients. And to share their insights and their experiences in this field, I would ask that the panelists introduce themselves briefly, say something about their connection to the topic, and also a personal statement about the topic. Maybe starting with Jordi.
Yeah, thank you, Jordi Parramon. I'm the co-founder and GP of a new venture capital firm that is called Nexus Neurotech. And it's a very kind of mission-oriented firm where there's a stream, I would say, focus in a few clinical indications, all within the brain, one of your three pillars. So we only do one, is brain. And within that, just a subset of clinical indications first that have a really high level of interest by the LPs for us to pursue. And so we're looking at opportunities in the space of Parkinson's disease, autism, and bipolar disorders. In terms of the stage of the companies we invest, we go all the way from seed to pre-IPO. So essentially, we're not limited by the size of the check, more by the strategic fit that these companies have into the things that we really want to do, which is providing better solutions for the patients of the disorders I just mentioned.
Thank you, Jordi. Caitlin?
Sure. My name is Caitlin Morris. I'm the CEO and co-founder of BrainSpace. We are starting with managing brain pressure, and that's done with CSF diversion. About a third of the patients that need that, it's for neurodegenerative cases. So we are looking at the aging brain. And then we're also really looking at on the neurotrauma cases. What can we do in the acute case when those patients are in the hospital to make sure they're not dealing with some of the comorbidities you were just describing that lead to increased chances of dementia and other challenges in old age? And so we're really looking at that both from a therapeutic perspective during the acute case, as well as what can be done more preventatively as we move forward. We have a device that we recently submitted to the FDA for and are going to be moving into clinical use.
And Branden?
Branden Rosenhan. I'm a critical care physician turned venture capitalist at MedMountain Ventures. We're a pre-seed seed venture fund that's healthcare focused. Of course, we're at a healthcare conference. Healthcare focused. We do medtech. We do digital health. We do services. The only thing we don't do is pharma. So I'm happy to be here.
Excellent.
Mhm.
Let's jump straight right in. Let's talk about unmet clinical needs. Branden, as a critical care physician, you also ran a network of ICUs around the country in the US. I mean, what do you and your colleagues see as the greatest unmet need in this space?
Yeah, so going back to, so I also was a patient. I had a hemorrhagic stroke and a TBI. So I've been both a physician taking care of ICU patients, for more than a decade, and then I became a patient. And so the thing that has not changed in intensive care units much is the way that we get the patients out of the ICU. So there's new therapies, but they're not across the finish line. They're not game changing for our hospitals. So the unmet needs are many. For example, the solution to delirium in the hospital is the most significant outcome is by keeping the window open and having the people understand how they should really feel and in the processes. So the short version is we have huge unmet needs. We haven't changed how we take care of hospitals or how we take care of patients in hospitals significantly for a long time. And we need to do that better because in 10 years, our hospitals will basically be intensive care units. You have to get these patients out of the acute care setting in a number of days, or they're going to have significant comorbidities and significant development of dementia and other problems.
Okay. And today we are talking about the aging brain. We're talking about the elderly. I mean, does the clinical trajectory for an elderly patient, is that any different from a younger patient, or are they do you treat them very differently?
Yeah, I'll have to I'll be criticized, whoever sees this or if it ends up on LinkedIn. But with my patients, I always sort of said that it was I worked at a long-term acute care facility as well. So that when the patients leave the ICU, we think, oh, they're going to be fine. But you're looking at months of recovery. So I used to tell patients, if every day you're in the ICU, you're reducing your strength in your your rehab for like 10 days. So it's sort of like a 1-to-10 ratio. If you've been in the hospital for 9 days, it's going to take you 3 months to get back where you were. And so the elderly are going to continue to struggle. They're already having atrophy. They're already struggling with their simple their daily activities. So yes, elderly will continue to struggle where the younger can bounce back.
Right. So slower recovery. And I guess diagnosis may be complicated as well because they tend to have comorbidities as well, right? They present themselves with a number of other issues. So being able to clearly identify neurological dysfunction may be trickier than normal. Is that?
Yeah. Your neurological impact can be from multi-organ failure, from you've impact the kidneys, you've impact the GI system, then the neurological components are significant still, and can be anyway.
So there's a saying in neuro, you injure the brain you have.
Mm-hmm.
But the problem is most people don't actually know the state of their brain is before that injury, before that trauma. And the older you are, the more likely it is that there's other things going on, right? So we've talked about specific comorbidities, but there's also related to atrophy, related to cellular degeneration, related to elasticity. And so one of those challenges also comes into play is you don't actually know when somebody's arriving at the hospital what their pre-state was that's going to influence all those outcomes as well.
So, I mean, to the entrepreneurs who are out there listening, I mean, clearly then this suggests that in designing a solution, you need to take all of these into account and find a way to partition or separate or identify these comorbidities, right, to clearly isolate the disease.
Yeah, and Jordi has a great, he's the expert on a lot of this components, and obviously the panel. The last thing I'll say is that well, see, there you go. There's my I forgot what I'm saying.
All right, Jordi, you're about to jump in.
Yeah, so, well, a very obvious, gigantic clinical unmet need is having disease-modifying interventions for these neurodegenerative disorders that just progress over time. This is like, if there's one single biggest opportunity to really make something as transformational, is figure out a way to slow down the progression of those diseases or even reverse them. Alzheimer has started doing that a little bit with some drugs that reduce the amyloid plaque, but still the clinical effect that they have is small. So the future of neurointerventions will have a very different scenario where there will be options to choose that can start making a difference in the progression of the disease. That's what we need.
Okay.
Yeah, and now that you reminded me, so when you're a physician, diagnosis drives therapy, and you've nailed it that we have these kind of therapies, but we're just learning. There's really good diagnosis. There's really good monitoring that's sort of been invented in the last decade. So we're seeing, but we're not going to improve significantly until we have great therapies.
Yeah.
So the starting point for any kind of therapy must be sort of data and knowledge. And the earlier we know what's going on, and the more we know what's going on, we have a better chance, or physicians have a better chance of addressing the issues, slowing the progression of the disease, or even treating them, right? And CSFs and blood are two rich source of biomarkers for neurodegenerative diseases and neurotrauma. Caitlin, your company, you spend a lot of time working on developing a solution for managing not just intracranial pressure, but also CSF. So what are the opportunities that you see here in this area?
Yeah, absolutely. So as Branden was just saying, it is a bit of a chicken and egg scenario, right? Because from a clinical perspective, if you don't know what treatment you're going to do differently, it's hard to justify that additional monitoring, that additional testing, the sampling, the biomarkers. On the other hand, if you don't have a way to stratify your patients, then when you get mixed outcomes, you don't really know, was that because you had a heterogeneous population, or is that because the therapeutic was not as effective as it could have been? And so one of the things that we're really looking at, and I think there's a real opportunity for in this next phase of medtech, is really to be data rich as a secondary benefit while providing a primary therapeutic benefit. And so we really look at that as there have been over 3,000 publications around CSF biomarkers in the last 20 to 30 years. There is significant scientific work being done, but until that translates to the bedside, it's not really making the impact for patients that we all want it to see. And so I think we have a real opportunity, whether it's vagus nerve stimulation or DBS on the electrical side, whether it's CSF drainage and some of the things that we're doing, is what data is being collected that helps better inform the populations that are benefiting so that we can then decide where those therapeutic pathways make sense. And so we're excited about that on the CSF biomarker side. We think there's a lot of opportunities in neuroinflammation, and specifically in the last 20 years, there has been work on what is dementia specific, what is Parkinson's specific, and that has been metabolic, protein-based. There's a number of different types of biosensing that's going on, but we really see that the time has come to be able to integrate those in a way that is meaningful therapeutically.
Okay.
And just to follow up on that, the importance of biomarkers are not just from a diagnostic perspective, having a yes, no, that you have a disease. This is an important first step. The value of biomarkers will be amplified once in the future you have good interventions. Then if the markers can make a measurement of the progression of the disease, then you can integrate it into your algorithm. And then with that, you can optimize the personalization of the intervention. So that's one thing which is super important, to look more for a quantitative marker than just a qualitative marker of yes and no. And your point you were making on data integration as a way to really have a role in how they manage this patient is very important, because the patient you go home, you live your life, and before the emergence of all these wearables and technologies that can have a sort of visibility of what you're doing, then you couldn't really do anything. But now that we have watches and phones and connectivity, internet, etc., all these digital elements that surround oneself can actually be used to manage better the disorders. Like one of the companies in our portfolio is called Rune Labs, and is on Parkinson's patients is a multimodal data platform that, among other things, captures tremor and dyskinesias from the Apple Watch. And the Apple Watch is connected to the phone, and the phone is connected to the specialist if you need it, or to these agents, AI agents, right, that provide lower head services. And it's a complement of what will also be a therapeutic piece as well, that the two things will work synergistically to improve the life of these people.
Yeah, absolutely. And that's actually, we've talked with a number of companies who are doing more the non-invasive or class 1 and really looked at how can we do studies together where we quantify, okay, here's what was happening in the acute phase, here's what it looks like 6 months later, right? And really be able to see that full patient journey. And the more that that's quantitative, we can address interoperator variability, we can address a lot of, okay, well, in this environment, it looked this way. And I think there's really an opportunity to paint that whole picture. And that's where the wearables and the non-invasive, as well as the obviously more invasive therapeutics, can really go hand in hand.
And I think what I'm hearing is that biomarkers are helpful, of course, but they're useless if they don't result in actionable clinical
You have to
changes.
to do something with it.
Right, you got to do something with that. So let's move on to neurodiagnostics. So biomarkers, CSFs, and blood are of course one way to access these biomarkers. Are there any other technologies out there? Any other ways of accessing these biomarkers and identifying them that you're aware of? Are there any other technologies out there?
I mean, it depends kind of how you define the term biomarker. There's actually a fair amount that's done in digital biomarkers as well. So you think about this on the physiological level, but even digitally, some of the derived biomarkers that exist from those parameters can be done. So it isn't just the biological analyte side, and that's actually where a lot of the Apple Watch type stuff comes in, is really more as a digital biomarker.
Yeah, I'll also add, on the imaging side, right now you have MRIs in one side, which has a lot of resolution in the spatially. You can see very little things, but very slow. And then you have EEGs, which don't have spatial resolution, but you see signals very quick. Ideally, we would like to find something in the middle where you can actually see how the brain behaves non-invasively with a time scale that you can attach it to labeling tags that can be useful to understand better. So if any one of the entrepreneurs has ideas how to develop this kind of technology, that it's something that is needed.
You're talking more like a functional MRI kind of thing.
But fast.
Yeah.
Functional MRI is very slow.
Real-time results.
Real-time MRI, that would be the ideal.
Right. So for the audience, the entrepreneurial audience, you've heard it. Real-time functional MRIs. That's kind of what we're looking for. Earlier we talked about different the publication of so many different biomarkers, right? I mean, there's amyloid, there's tau, there's kinases, a whole bunch of these. For amyloids in particular, for instance, there are we're aware of at least 3 or 4 companies that are now trying to identify amyloid deposits or amyloidosis through ocular amyloidosis, so through the eye. So, the next time you go and see your optician or your optometrist, you could not, in addition to just getting your eyes checked for clarity and all of that, you may also be doing a dementia screening or an Alzheimer's screening, right? So those are the kind of technologies that are out there. Anything else on diagnostics anyone wants to add?
I think that they both sort of nailed it. I mean, in your diagnosis, your diagnostic or your monitoring has to be able to be sensitive and specific, and it has to be able to do so quickly. And if you don't have a therapy, she and I were discussing last night that she has this awesome data coming of what's going on in the CSF. What does it look like? How can I optically provide information? And I can do it real time, and I sort of kept saying, but what are you going to do with the result? If it's in, this kind of ties into what Jordi says. If the result comes in 5 minutes, what are you going to do differently? If the result comes in 5 hours, what are you going to do differently? So from the physician side that I taught these young, the training doctors, it's like, okay, why are you going to order this lab? Well, I ordered it yesterday and I want to know what's going on. I said, will you do something different if the result is different? You shouldn't draw the lab again. So we have to have real-time information that we can act on. You've said actionable before. So I think Georgie's right. Sorry, I keep saying Georgie. Jordi.
Yes.
Okay. So let's talk about action then. Let's talk about treatment and therapies. One approach is of course surgical, but nobody likes to have their brain crack open for something like that. So the trend is towards sort of neurostimulation, minimally invasive sort of therapies. Over the last 2 years, we at Hunniwell, we've been curating a group of companies for our investors, And we see an explosion of activity in the neurostimulation, neuromodulation space. That's really sort of matured from, 2-3 years ago, where you're seeing most of what you're seeing are sort of consumer grade pain management devices, the type that you see at a consumer electronics show, right? With dubious, many of them with dubious claims, dubious clinical claims, to now graduating to clinical grade devices. They're all coming of age. These are, vagus nerve stimulation, some deep brain stimulation, transcranial stimulation, sacral nerve stimulation, addressing not just dementia, Alzheimer's, and stroke rehabilitation, but even things like bladder control and erectile dysfunction. So there's an explosion of these. Jordi, what other opportunities do you see in this space?
Well, I started working in the space in the late 90s. So if you ask me then, neuromodulation, if you ask me at that time, how would the future would look like 25 years from today, which was today, I was imagining that we'll be having neuromod everywhere. And the reality is we don't. I think we screwed up big time, the industry-wise, because we've been focusing a lot in a very few indications that had high gross margins, so make good business, but very low penetration. So if you look at the number of people that get a deep brain stimulation or a spinal cord, all this is still very small. So we have not really tried to address the question of how to scale those kind of interventions. And I think over time, people are starting to realize that if you don't find ways to scale, the business are very hard, right? It's because they're very capital intensive, very risky, long term. So that's a little bit of the challenge, I think, is how we can make the penetration of interventions go from a 1 to 2% to something like 20, at least 20%. Hasn't happened yet.
What do we think is the barrier here? I mean, what's keeping this from exploding the way that we think it should? Why isn't it taking off?
Well, it depends on. So if you look at deep brain stimulation, you need a functional neurosurgeon to the procedure. How many functional neurosurgeons are in the US, and what is their growth over time? That's it. There are the same number of centers today than 25 years ago. So that's one thing, right? The easy of the intervention. The other thing too is who likes to have his brain open, right? Put a hole in the brain and put electrodes inside. That's not funny, because, so the more interventions that will be less invasive, that will be more conducive to acceptance, that will be easy to practice clinically, the more these things will impact people. That's why, for example, we invest in companies that are trying to use this approach as well, like Focus Ultrasound. This where one of our companies is Insight Tech, and they're doing amazing things. You can target 1 millimeter of neural tissue deep into the brain, super high precision, and you get your tremor gone without really opening your skull. That's an example.
Well, since you made a pitch for Insight Tech, I'm going to make the pitch for Synaptica, which is a transcranial stimulation device designed to enhance neuroplasticity and improve brain connectivity and neural connectivity. And early studies seem to suggest that for Alzheimer's dementia patients, 33% showed no progression after the use of the device versus 17% in a placebo. So not quite the silver bullet or the golden bullet, but I think that's an improvement, and that's a solution that's out there for many people.
Oh yeah, I mean, and I know well Ken, the CEO that was in Synaptica, and they have to now they're on this journey of increasing the quality of the clinical evidence with multi-centers and more statistics. But I think the idea of using a modulatory intervention to force plastic changes that have a memory effect that could reinforce sort of networks in the brain that could have therapeutic value, it's super valuable.
Jordi, I think to your point as well about how long it's taken and kind of why are we taking so long, right? Why haven't we gotten there by now? I think when you ask about what percentage of people are adopting these technologies, one of the challenges when I talk with patients is that if you tell someone they have stage 4 cancer, there is a pretty clear take action or you die, right? There is a stimulus in that environment to say, you must do something.
Mm.
And the question is, what are you going to do? With a lot of neurological conditions, the belief right now on where we're going to have the most impact is earlier on. But at that point, they're not facing that level of urgency.
Mhm.
And so to do something that feels aggressive and high risk when
Mhm.
you're potentially jeopardizing your good years
Mhm.
is I think a little bit more complicated. So when you think about it from the patient perspective and from the family member's perspective, they're sometimes going to say, well, let's see, maybe it's not that bad. If it's still getting worse in a few months, maybe we'll go to the doctor, right? And so I think part of the challenge also becomes, if you don't know what that progression is going to look like,
Yep.
knowing what risks you're willing to take can also be a challenge.
So I think we've identified risk and perceived risk at least, and sort of the trauma of having something drilled into your head as obstacles. I would also suggest that maybe even stigma could be a business a barrier, right? The fact that even for, say, a vagus nerve stimulation, I mean, people can kind of see that there's something there, and it doesn't feel normal in that sense. And so stigma could also be keeping a lot of people from seeking treatment or making themselves available to the kind of treatment and solutions that are out there. In the final 3 minutes that we have left, I want to ask each one of you, starting with Caitlin. So, having worked in this space for such a long time, I mean, what do you and your colleagues, your entrepreneurial colleagues, what are you guys excited about in neuro? What do you see as the most exciting things going forward over the next couple of years?
Yeah, I will say before launching BrainSpace, I had worked in a number of different products across a number of different spaces. And one of my favorite things about neuro is how much is still not yet figured out. So in the early days, I would talk to an intensivist or I'd talk to a neurosurgeon. I'd say, okay, explain to me this. What about that? And eventually they'd go, look, Caitlin, nobody really knows, but here's what we teach our residents. And that idea that compared to, say, maybe where heart was in the 80s and 90s, there's still so much opportunity to be able to make real meaningful progress for patients, for families, build meaningful businesses. It's still just so much of a blue ocean compared to a lot of other parts of medicine that I think MedTech really has an opportunity to shine here.
Okay, thank you. And for Jordi and Branden, think about, as you approach your investments in neurological space, is there anything unique that you're looking for in these kind of investments that you might not perhaps look for in others areas? I mean, for instance, for us at Hunniwell, when we are looking at investment in neurological space, beyond the clinical data, which is of course important and necessary, we also want to try and understand, if possible, the science behind it. So a bunch of correlational analysis, saying if I do this, these are the outputs and these are the outcomes, is enough for the FDA, but it doesn't quite satisfy our investors. They want to understand the science and the chemistry or the physiology behind it. What do your investors, or what do you look for in your investments?
Well, mechanistic action understanding is a piece. The problem with the brain is that at the same time is the opportunity, is that the science is very limiting. And once you get into this kind of complexity of an organ, which is orders of magnitude of anything else that we know in the universe, on everyone, then the question is that trade-off between how much money you want to spend on the science versus how much money you want to spend on the clinical evidence that you have to generate anyways, right? So then, and that's I think it's case by case depending on the
And Branden, 30 seconds.
Yeah, the short version is I'm going to be contrarian as sort of either the venture guy or the financial guys. You have to figure out, you work on the science, you work on the clinical studies, but there's still always going to be debate on like how good that is, right? So you need to think about how are you going to get not just reimbursed, but create a business that can succeed and that can grow so that you can then redevelop the science. So it is a chicken egg thing, but so that's what's exciting for us, and the things we look at is really if you can get off that initial ledge of creating revenue and making the company succeed, you can do really more exciting things.
Thank you, Branden. And on that note, we conclude this panel on the aging brain. Let us give a round of applause to our panelists and thank them for their insights. Thank you.